our neuroradiologist, Dr. Whitney Pope, our neuropathologist, Dr. Fausto Rodriguez. And from neuro-oncology, we have Dr. Cloughesy, Dr. Albert Lai, and I'm Dr. Leia Nghiemphu. So nice meeting everybody. I'm gonna go ahead and start the session. So pretty much we'll just jump right in with the first case. So the first case is a 58-year-old gentleman who presented to the hospital with a generalized tonic-clonic seizure and was placed on a seizure medication called levetiracetam. And really the only history in the past that the patient has had is hypothyroidism. So because of the seizure, the patient had an MRI of the brain that was obtained. So like Dr. Pope, if you could explain the MRI.
Sure, we're looking at the same slice through the brain, but with two different imaging techniques. This one here is T2 imaging, and this is T1 imaging with intravenous contrast. And so what we see is we see a lesion here that has mass effect. So we have a mass lesion that's bright on T2, and it shows irregular contrast enhancement with a central area that doesn't enhance, suggesting this is a necrotic mass surrounded by edema. So it looks like an aggressive tumor.
Do you have a differential diagnosis?
Sure. So there's a classic differential diagnosis for ring enhancing lesions in patients in the brain that include primary tumors, so tumors that arise intrinsically in the brain, secondary tumors, so that would be metastatic disease. You can also have infections such as brain abscesses, and then the other things would be, more uncommon. You could have demyelinating disease, for instance, although that doesn't typically have such a necrotic appearance.
Thank you. So the thought is whether the patient should have surgery, resection of this tumor. So Dr. Everson, if you could chime in.
Yeah, so when we see a newly discovered lesion in the brain like this, we'll typically want to do a evaluation to determine whether or not we think it's a primary or metastatic brain tumor, scanning other parts of the body as needed to understand if that's the case. If all the signs point to this being a primary brain tumor like a glioma, then surgery is going to be the next order of business. We do this for a couple of reasons. One is to confirm the diagnosis by getting some portion of the tissue to pathology for detailed analysis. The second reason is for cytoreduction, reducing the number of malignant cells and the burden of disease. And along with that reduction of the number of cells, the mass effect or the pressure that the surgery or that the tumor is creating can be reduced, and we can ameliorate some symptoms. But figuring out whether or not or how we are going to do a surgery requires some detailed planning of what areas of the brain are safe to enter or not. And if we can go to our next slide, we can illustrate how we do this type of mapping in the preoperative phase to make sure that we can safely enter and remove the vast majority, if not the entirety, of a contrast enhancing lesion in the brain. And so it depends mostly about where in the brain a lesion is located anatomically. That gives us some idea of what functional parts of the brain or what functions might be at risk with a surgery in that area. When a tumor like the one that's shown here in the left posterior temporal region is at play, we worry about things like language. And in order to evaluate that, we can get a specialized type of MRI called a functional MRI, which measures blood flow changes proportionate to areas of the brain that are used for a given activity. And that's what's shown in the bottom there, with the orange regions, being the areas of the brain that light up when a given task is being performed, in this sense, language. We can then translate those into three-dimensional maps, which are is the next window there, and overlay that relative to the tumor. So what we're seeing here are areas of functional language activations, which are in pink and blue, as well as the tumor itself in this instance, which is highlighted in purple. And we can see that they're in the vicinity. So in this, an operation to remove this tumor, language, for example, might be at risk. Refining our pre-surgical map, we can actually look beyond just the areas of the surface of the brain and where they're active in these tasks, but look at the connections between the two in the subcortical space, which is done through yet another imaging technique called diffusion tensor imaging, which basically follows the path of the connections between the nerve cells in the brain in and around the tumor in the subcortical space. So that, again, gives us a map of where we can and can't reasonably go surgically and what functions will be at risk. Now, in the previous example, so if we go to the next slide, this tumor is in a region that is potentially near the optic radiations or some visual fibers, but using our mapping techniques, we can see that they're actually located somewhat safely away down here in yellow in the bottom left panel. And the mass also appears to be safely behind the red tracks, which are the sensory fibers. So when something like this is sort of located in between some functional areas, but has an open corridor to reach, we can use this pre-surgical map to tell us it'll be safe to go in and go after this mass in its entirety. And in this instance, that's what we're able to do via a craniotomy, which is shown depicted in relatively graphic detail on this slide. This is what we might see at surgery for a mass that's presenting on the surface. And what you're looking at here are in the green on the periphery is are little clamps that are on the scalp, staunching any bleeding from the scalp. Below that is the bone, the skull, which has been cut with a craniotomy. Then one layer beyond that is the dura, which is also reflected. And then we're looking at the surface of the brain. Now, the normal unaffected brain is sort of this peach color, and we can see the vessels in the surface and in the wrinkles of the brain. And then, the mass in this instance is quite apparent on the surface as this red sort of vascular, often very pulsating type of mass. And this one has a very clear distinction from the surrounding brain. And that's not always the case. We know that these can have diffuse patterns of growth, but in instances like this, where it's relatively circumscribed and identifiable, we can achieve a resection, remove it with very, very clean margins, as one like this might have more compact margins rather than diffuse. And at the end, with the mass removed, you're looking at a cavity of sort of empty space here on the right-hand side. And on the next slide, our post-operative imaging shows that in this instance, we're able to remove all the contrast enhancing parts of this tumor safely by using our preoperative mapping to ensure that we're entering into a non-eloquent region of the brain. And by doing so, effectively remove the contrast enhancing lesion in its entirety.
I just want to confirm with Dr. Pope that is there anything else worrisome that you see left on the MRI?
Yeah, no, this is a very beautiful and clean resection with no nodular enhancements and no hazy T2 signal abnormality to suggest any kind of residual enhancing or non-enhancing tumor. So I think this is about as good as it gets.
Once we have surgery and tumor removal, the tissues are sent to our neuropathologists. So I'll ask Dr. Rodriguez to comment on the neuropathology.
All right, so these are stains, and I think show some in the earlier lecture of the brain tumors, how we stain the cells. We use a very basic stain to start, which is hematoxylin and eosin. Hematoxylin has this purple type of color, which highlights the nuclei, and eosin is more the pink, the cytoplasm. And it gives a lot of information about the tumor types to get started. This is an astrocytic tumor that is infiltrating the brain and has some very worrisome features, which include mitotic activity, microvascular proliferation, and necrosis on the upper left panel. All those features taken together allow us from the pathologic side to reach a diagnosis of glioblastoma. There are some special additional immunohistochemical stains where we stain for specific proteins to help us characterize it a little bit better. Especially for GFAP, that's a feature of astrocytes, both astrocytes that are present in the brain and also in tumors that are made of neoplastic astrocytes. Ki-67 is a measure of proliferation. This is 40%. That is high. This is usually the normal brain has a proliferation near zero, essentially zero, and very low grade processes, infective processes have 1 or 2%. Anything above that usually tends to be associated with tumors. And at this higher end, these are really very proliferative tumors, something that is very worrisome when you see it in tumors in the brain. IDH1 was negative. It's one of the markers that we use. And I think I highlighted some of that in my earlier lecture. It is a mutation that when present, these diffuse gliomas in adults is associated with a better prognosis. And it's a completely different tumor types. It will not even be called glioblastoma anymore. So that removes it and put in the astrocytomas IDH mutant. Unfortunately for this patient, this was absent. So we start with an immunostain, which recognizes the most common mutation, but the sequencing sometimes is a second step that allows to look at it by PCR for other alterations that are a little bit less frequent in the same gene. MGMT, I think some of that has been covered as another marker for very important for prediction to treatment, something that we send for. And EGFR fish. EGFR is a gene that is frequently amplified, or meaning that you have multiple gains of this gene that is associated with increased proliferation and survival in these tumors, of the tumor cells. So it's a bad thing to have it, but it's characteristic of a subset of glioblastomas. And when present, allows also, even if we don't have all the histologic features, to put it in that category. So the final, what we call integrated diagnosis, where we use all this information to make a diagnosis, is glioblastoma IDH wild type. Is WHO grade 4 by definition, which is the highest grade that you can have. So it's not a good thing to have. And in addition, we add some of the other prognostic information like MGMT status, which help our oncologists then make subsequent decisions.
Thank you. So at this point, we need to decide on treatment options for this patient. So I'm going to read this off, and then I'll have more discussion about these later on. So, options for patients at this point could include radiation with concurrent adjuvant temozolomide, which are pretty much our standard therapy. We can also add, have option 1, and then also add the TTF tumor treating field from Novocure with adjuvant temozolomide, again, still part of standard therapy at this point. Third option would be including radiation and current temozolomide, and also consider clinical trial therapy. And I think I'll leave option 4 for a little bit more explanation in a little bit, but there's also thought that perhaps patients could go into a clinical trial with radiation without temozolomide chemotherapy. And of course, it's never a wrong decision to have just supportive care at this point and not go through with active therapy. So Dr. Cloughesy, I'm going to have you take over and explain why these options.
Sorry, I had to unmute. First, for many years, radiation therapy was the standard of care for glioblastoma. There was a study done in 2005 that showed that adding chemotherapy to radiation therapy, and that's given daily from the beginning of radiation therapy to the end of radiation therapy, 7 days a week. And then after a rest, when the radiation therapy has completed, a rest of about a month, and then starting chemotherapy with 5 days on, 23 days off, and repeating 28-day cycles up to 6 cycles, define the standard of care because of the difference that you see between these two curves, the dark blue and the gray curve. The gray curve is with chemotherapy, the dark blue is without chemotherapy. And although the median survival, the improvement was really just 2 months, as you see, as the curve continues to go, you see it's separating more. And I think that's the more meaningful finding, is that that there's a higher percentage of patients, let's say at 2 years, that, you know, it's 70 or 27%, excuse me, are still alive at 2 years. At 3 years, it's 16%. At 4 years, it's 12%, whereas in the radiation therapy alone, it's certainly less than that. So this is really what established the standard of care that we even use today, along plus or minus the use of the TTF Novacure.
Right. Do you want to talk a little bit about any clinical trial options at this point also, although we don't have a slide, but you know, we can talk
yeah,
about
I mean, the idea normally is that when clinical trials are used, you layer it on top of the standard approach. So that would mean, and let's imagine there was a therapy that was going to be used. It could be used with radiation if it has some evidence of being a radiation sensitizer in some way, or could be used along afterwards in the maintenance period with temozolomide, or it could be used in both settings. A lot of the decision about where it gets placed depends upon the mechanism of action and the potential for interaction and toxicity associated that could be associated with that agent and radiation therapy. You talked about, and is this where you'd like me to say something about, I think it was choice 3 or 4, whatever that was, about taking away temozolomide? Yeah, do you want me to speak about that now or later?
Sure.
So, you know, MGMT methylation status, I think you probably heard with Dr. Lai, really defines the population that derives most of the benefit. So when we see this benefit in this curve, it's really being driven predominantly by the MGMT methylated population. And that means the methylated group doesn't have as great a benefit with the addition of chemotherapy. So we're always looking for better ways of doing things. So, you know, one of the options is to not use temozolomide in the patients who are MGMT unmethylated, and to add a clinical trial agent, either again on top of radiation therapy or to follow after radiation therapy, or both. So it provides us with a little more opportunity to use higher doses of the particular drug we're interested in studying, especially if there's some interaction with temozolomide and we have to lower the dose because we maybe have too great of an effect on the immune system, dropping blood counts, white blood cell count, or platelet count. So this just knowing this and having this understanding and knowing that we really would like to see much better outcomes associated with the unmethylated population, that's where a lot of clinical trials move forward, because it's the ease of use, being able to take away temozolomide and to move forward with these therapies.
So at the same time, the patient would need to also have radiation therapy. So Dr. Kaprealian, if you want to explain how radiation is planned on this patient.
Yeah, the standard of care for a high-grade glioma and the sitting in glioblastoma is to deliver 60 gray. That's the unit of radiation. We deliver it in daily fractions and treatment plans that are identical for 30 treatments. So it's 2 gray per day for 30 treatments. Every day is the same plan and treatment. And what you see here is a treatment plan, essentially. What you have highlighted in red is the tumor resection cavity that we saw. And then what's surrounding in this light blue color is the margin that we add. And I get a lot of questions from the patients about the margin that we add. It's still focal radiation focused in on that tumor area, but the way I ask my patients to think about it is like an octopus, where the head is what we're seeing and what's resected, and then the tentacles are what's hidden inside the brain. And we want to make sure we cover that too, because we know that there is tumor there. And so for each type of tumor, there's established margins that we use. So it's pretty consistent across the board and institution to institution, with minor variations that end up being approximately the same. And so you're delivering the highest dose, your prescription dose, to that area. So the red is the 60 gray. And as it tapers off, you get some spillage of dose that you can see in blue, green, and yellow. And as it gets farther from that site, that it's less spillage dose in that area. So that's what you're seeing.
So this patient actually chose to enter a clinical trial where he received an EGFR inhibitor together with radiation with concurrent temozolomide, followed by adjuvant temozolomide and the EGFR inhibitor again. Several months later, he actually had some MRI changes on the scan. So I would say this is, well, about 6 months out from treatment. So Dr. Pope, if you could have some discussion on these scans.
Sure. So both of these, this image is in the coronal plane, post-contrast T1. This is in the axial plane. And both of these images show some nodular enhancement at the margin of the resection cavity. And so anytime we see rounded enhancement that's associated with some mass effect, perhaps some edema, then we become concerned that this could represent recurrent tumor, although sometimes the treatment results in a similar appearance. So we have to try to distinguish between treatment effect and actual tumor recurrence.
Sorry, this is the before and this is after.
So, so one of the ways that we can do that is we can look at the blood flow to the area of concern. So for instance, in this case, you see this area of enhancement adjacent to where the tumor initially was. And if we look at the blood flow, which is illustrated on this image, where higher blood flow equals red and green, we can see that instead of there being dark blue in this area, there is some red and green that indicates that there's increased blood flow to that area. And that's more typical of actual living viable tumor rather than radiation necrosis or treatment effects. So if we see this increase in perfusion in areas of nodular enhancement, then we definitely are concerned that there is actual tumor recurrence. Conversely, sometimes we have areas of enhancement and we can look at the perfusion imaging and we don't see any of the red areas that suggest that there's a lower amount of blood flow into that region. And so therefore we would be less concerned with tumor progression, but we have to remember it's not an all or none phenomenon. And so there can be a range of perfusion within this area, these areas, and the higher the perfusion is, the more convinced we are that you have tumor recurrence. But here it's a little bit lower. And here we can see that it's on a follow-up scan, it's quite low in that area. So therefore, we would have less concern that this is tumor recurrence. The only way to prove it, though, is not with imaging, but actually to get some of that tissue resampled and have the neuropathologist look at it under the microscope. But we can make an educated guess, I would say, based upon the imaging.
Right. So kind of just summary on this case as we move on is the patient in the newly diagnosed setting received radiation therapy with concurrent temozolomide followed by adjuvant temozolomide chemotherapy. Just as a reminder, there is the alternating tumor treating fields that's also FDA approved for in the setting of adjuvant temozolomide that can be used at the same time. However, the patient chose to go into a clinical trial, so did not use it at the time. When we have recurrent glioblastoma, we do have to make a decision about whether it's true progression versus pseudo progression. And if there is definite progression, there's also clinical trial options that can be explored. Actually, I have a quick question for Dr. Pope. Like usually when do you think we would see more pseudoprogression after radio and chemotherapy? And not Dr. Pope, anybody else can weigh in too, actually.
Yeah, so I say the most typical time frame for pseudoprogression would be 6 months after therapy, but it can certainly come a little bit before that, a little bit after that. However, when you get to the 6 month and beyond, then more often you're dealing with classic radiation necrosis rather than pseudoprogression. But we can lump those kind of together, pseudoprogression and radiation necrosis, as treatment effect. And the fact is they both can mimic tumor recurrence.
We'll start with the second case. This one is a young-looking 79-year-old right-handed man who had actually no previous past medical history. He had a sudden fall and was taken to the emergency room. And because of the fall, he needed imaging of his head and then a subsequent MRI that revealed a right frontal mass. His medications were then, he was then placed on levotirazone. Otherwise, very good functional status at 90%. So, Dr. Pope, if you can go over the imaging.
Sure.
So just dates.
Okay, so this is from 2014, and we again have a T2 weighted image and a pre-contrast and post-contrast T1 weighted image. And we can see right away that there's a large area of abnormality in the front half of the brain, centered in the frontal lobes, where you see all this bright T2, this more white T2 signal intensity. And then if we look on the post-contrast images, there's areas of avid enhancement within that larger area of abnormality that we saw in the T2 weighted images. And again, we see this non-enhancing irregular portion centrally to these masses. So that suggests a necrotic, higher grade tumor.
So, Dr. Everson, what do you think about doing surgery on this patient?
Yeah, so there's a couple of important considerations I think to make on this situation compared to the previous one. You know, one is the age and sort of frailty or robustness of the patient and their ability to undergo an operation safely and recover from it. Now, in decades past, you know, doing a craniotomy and resection of a brain tumor on someone, you know, in their 80s and 90s would have been, you know, looked upon as futile or unnecessary. You know, in more modern times, as we have improved and refined surgical techniques and decreased our complication rates and just gained more experience with it, is much more feasible and a safe concept to, you know, take such a patient like that through an operation and expect a good recovery. So that's one aspect of it. Now, the second is the anatomical features of this tumor are pretty different from what we saw before. You know, in this one, we see two major components of this. One is the large mass in the, you know, in the frontal lobe. Then there's this other portion which really reaches and extends across the midline, across the corpus callosum, and goes to the other side of the brain. And so thinking about those two, you know, components separately, you know, knowing the functional or anticipated functional effects of removing each one is quite different. You know, the portion that's in the right frontal lobe, one would expect very little in the way of major functional side effects, but the part that's reaching across the corpus callosum, you know, reaching that, number one, increases the complexity, the technical aspects of the surgery is not always as feasible to really reach over there and remove that portion. And secondly, can lead to types of symptoms post-operatively related to disconnection in terms of severing the connection between the hemispheres of the brain, which can affect things more often like personality, higher cognitive function, executive function, things like math and reasoning, and some higher order cognition things that are sometimes subtle to measure, but very much there. So that's a little bit more of a challenging area to reach surgically and with less rationale to do so. Now, one of the things that we can get beyond this is some more refined imaging to understand biologically or metabolically which parts of the tumor might be more active and have more rapidly dividing or more malignant cells in it. And so that's where advanced imaging modalities like our DOPA PET scan, which is shown here, or some of our cerebral blood flow and some other types of MR techniques can be used. And so this DOPA PET scan here is going to show basically amino acid metabolism in the tumor, and it's shown on this gradient scale where the red area is really a very metabolically active part of the tumor. And so that adds further rationale to target that area specifically to kind of get the most bang for our buck, if you will, for removing more aggressive components of disease. Whereas the portion that is going across the corpus callosum is not as metabolically active. Therefore, if there's a part of this to leave in place and not risk these levels of complication, it's that part there. So combining these two modalities, understanding the anatomy and functional implications, as well as what's happening metabolically, create a strategy where going after the big bulk disease that's in the frontal lobe makes sense, where chasing the components that go across really don't. And so that's the kind of strategy that's undertaken in this patient here. And our next slide shows what we're able to achieve surgically with removal of really the large mass in the frontal lobe and stopping the resection as it starts to enter into the corpus callosum and cross into the left cerebral hemisphere.
We'll discuss the neuropathology on this patient, Dr. Rodriguez.
All right, so we may say that some of the features here from the neuropathology are similar to the previous one. We do have a proliferation of neoplastic cells, what we call neoplastic astrocytes in between. It's two cellular for normal brain, and it's composed of tumors that have a lot of processes, and which is typical of astrocytes, and have these, and where it's labeled as MVP, that's microvascular proliferation. That is always a worrisome feature in some of these diffuse gliomas. So that kind of starts suggesting, even at this power, that it may be a more on the higher grade end of the spectrum. So next. There's necrosis as well. So many of the features that were present in the first case are also present here. And so you have necrosis, you have proliferation, microvascular proliferation. That's always, again, a very difficult problem. These are features that are worrisome, everything else being equal. On the right-hand side, there's something that is being highlighted, is oligoendoglioma-like components. We historically always get like to see if there's any areas that portend a better prognosis, and oligoendoglioma historically that has been the case. So we try to find areas like this. You see, compared to the other fields, this area, the cells are round and have these clearing around the nuclei, which is very typical of oligoendoglioma. We want to make sure that we don't miss that, since those are tumors that have a much better prognosis compared to the astrocytic diffuse astrocytoma. So, and now there has been a lot of debate through the years of what to do when you have part of the tumor has these. And there was a term in the past that was called oligoastrocytoma, or mixed neoplasm, or mixed tumor, but it's actually being superseded more currently by molecular information. So if you see the WHO classification as it changes over the years, this was recognized in the past as a glioblastoma, which is because glioblastoma is an astrocytic tumor. And in the past, in the 2007 classification, there was a recognition that you can, if you identify areas that look oligoendoglial, you can add it to that, with the idea that some of these are portend a better prognosis. With time, now we know that what is more important in the context is that is the alteration. So if you don't have 1p19q deletion or IDH mutation, so it's negative also for IDH1 by immunohistochemistry and by sequencing, and then there's no 1p19q deletion, you cannot call that oligoendoglioma. That defaults it into the astrocytic category. And since it doesn't have IDH1 mutation, that will make it IDH wild type, and then you have all the other histologic features, necrosis, proliferation, that allows us now to put it more confidently in the glioblastoma IDH wild type category, even if it has areas that somewhat resemble a better tumor. So the genetics here drive us confidently in the direction of glioblastoma. And that is really the difference. I tried to highlight that in my lecture earlier, the difference with the new WHO classifications, that these molecular alterations that we understand are helping us to be more objective in actually adding more precise information to our histologic diagnosis. So the diagnosis is similar, and now also you have the MGMT methylation that we add. This one in contrast to the other one, so there is something biologically that is better. Here is the presence of the MGMT methylation, which is a good thing for treatment purposes. So the histology here is similar to the previous one, has areas that are a little bit what we call bland, that it makes you think about an oligoendoglioma, but molecularly ends up not being, but then has something biologically that is also a bit more favorable, which is the presence of MGMT methylation.
So at this point, the patient is then sent to see neuro-oncology and radiation oncology, and we also have to make a decision about how to treat these patients. So if you remember, Dr. Cloughesy talked about the very old data, as someone pointed out, of standard treatment for glioblastoma using radiation with temozolomide chemotherapy. However, that trial actually excluded any patients over the age of 70. So that trial actually technically does not apply to this patient who is 79 years old. So the question is then, how would we treat a patient who is older in age, even though he otherwise had very good functional status and is otherwise doing well? So in this patient population, again, I always want to make sure that despite being oncologists, we always say it's a reasonable option to think about supportive and palliative care, but we can also think about treatment. Is it popular to do treatment with temozolomide chemotherapy alone, or with radiation alone, or with combination therapy? I was hoping, Dr. Kaprealian, if you can help us maybe understand the difference between the hypofractionated and the standard protocol a little bit of radiation.
Yeah, of course. So the standard radiation we went over in the prior case, which is 60 gray in 30 fractions. But one option for certain groups of patients, one being those over 70 years old, is a shorter course. So 40 gray and 15 fractions, which has shown in these studies to be equivalent in the short time span with the 60 gray and 30 fractions. So the next slide shows a study, one of these studies that was done using this course, comparing doing nothing, so just observation, with radiation alone after surgery. And the study was stopped early. There was a short benefit of a little under 3 months, 2.8 months with the use of radiation alone. And the outcomes were relatively equivalent with the 6-week course. And so when we are faced with making this decision in this group of patients, we talk as a team to see if the patient has a good performance status, if they're able to come in for 6 weeks. And if not, then we can consider the shorter course, which is that 3-week course.
And Dr. Cloughesy, you want to talk about some studies that talk about just using chemotherapy alone in this population?
Sure. One of the reasons why on that original study that they didn't include patients who were over 70 was because it was predominantly done in Europe, and Europe had been doing evaluations and trying to understand what the impact was with radiation or chemotherapy and patients who were over 65 in particular. I'll also say just, I think in general, I wouldn't pay attention to these median overall survivals. Many patients who are in their 70s or 80s can end up doing fairly well. And the ones that are selected from many of these studies are the ones that they didn't think that the investigator didn't think could tolerate the full dose of radiation or the chemotherapy. So this is usually a patient population that isn't functioning as well. And so these numbers look a lot worse than we're used to seeing. But one of the studies that was done, this NOAA 08, was an evaluation that looked at giving patients radiation therapy, and then upon progression, they would get chemotherapy, but not as adjuvant, or they would get chemotherapy, and then upon progression, they would get radiation therapy. Basically, when you look at those data, the median survivals are similar between the two. I think the next, so this next slide really gets at trying to differentiate between the impact of the patients who are MGMT methylated, like this patient is, versus those that are not MGMT methylated. And this, let me see, I know that Dr. Nghiemphu is going to help me point these things out, but I might as well see if...
You can annotate, Dr. Cloughesy, you know how.
Yeah, I'm wondering, the mouse, I could use the mouse. Okay, let me know if you guys see this. Do you see this or not really?
No, you have to do the drawing.
All right, I'll do the drawing.
Arrow, maybe.
Okay, so this, where I put a little circle, and this here, where also I put the other little circle, are the patients that are MGMT methylated, I believe. Let me see if I got that right. Yeah, I think that's
correct.
right.
Yeah.
So the group up here in this area is the group that received temozolomide, and this is the group that received just radiation alone. And what you could see is and this is overall survival. So this is how, the patients eventually survived. So there was an improvement in overall survival in the patient population that was MGMT methylated, that received temozolomide alone, and then later went on to receive radiation if there was tumor progression, compared to the group that just received radiation alone. There was, in the end, their final analysis, which was done later than this, showed that there was a statistically significant difference between those two. On the contrary, if you're MGMT unmethylated, and let me get rid of my little circles here for a second. This group here is a group that got temozolomide, compared to the group that's intermixed here that you'll see that received, this group received temozolomide and the other group received radiation. You can see that the MGMT unmethylated population that got temozolomide first, and then eventually followed by radiation, and those who got it did much worse than those who had received radiation therapy initially. So in the patient population that is older, we tend to think there's an opportunity, depending on what's going on with the patient and what their functional status is, of giving temozolomide alone instead of giving radiation at that time, and maybe potentially holding off to give radiation. Of course, that would not be a consideration at all in an unmethylated population. I don't know if Dr. Kaprealian has anything to add to that, because I just want to make sure we have a good balanced discussion on it.
Yeah, I completely agree. As our team here knows, when we're faced with some of these patients and cases, I'll often chime in, and I also agree if we can do Timidar alone first, and then we see how the patient's doing, potentially even shrink the area so that if and when we do have to do radiation, maybe it'll be a smaller target. So I'm very supportive of this approach.
Dr. Cloughesy, you want to continue with this
Yeah,
trial?
and so, none of those studies addressed the real issue, which is, okay, well, and they're still not going to completely address it. The question would be, how do patients over 65 do when you do radiation versus radiation and chemotherapy at full dose radiation therapy? That is not going to be answered, but the study that was done in Canada was a study using this short course of radiation again, and they randomized patients to receive radiation therapy alone. Again, this population who's over 65, and again, probably poor functioning because the investigators thought they wouldn't be able to tolerate a full dose of radiation. Compared to the population that gets this short course of radiation plus daily temozolomide followed by temozolomide 5 days on, 23 days off. And you can see the blue is showing that there's an improvement in overall survival. That's essentially showing that the addition of temozolomide is beneficial. And I think even if the next one maybe shows issues around MGMT methylation status, I don't know if you have that or not. So this, and again, the majority of the effect that we see in that original population comes from the MGMT methylated group. Meaning that they get the best survival compared to who are getting chemotherapy compared to the group that got radiation alone. However, it should be noted that over on the other side here, where we show the MGMT unmethylated, that those patients also have a statistically significant or near statistically significant benefit of overall survival when adding temozolomide to radiation therapy compared to radiation therapy alone. So it does pretty much mimic what we're seeing in the population who is under 70.
So pretty much what this patient then ended up doing is actually ended up getting, well, kind of summary of what we were trying to say is that in patients who's methylated for the MGMT who is older, the decision could be short course radiation with temozolomide, better than, but temozolomide alone may be a consideration, again, depending on a long conversation with the patient, versus in the unmethylated MGMT patients, we'd recommend that they should have some form of radiation therapy. And it seems that at least it's also okay to do short course of radiation. Unclear if one is better than the other, right? With current data, whether the long course is better than the short course or not, we actually don't know the answer to that. But at least we know the short course with temozolomide is a safe option for the older patient population. These are some of the criteria for deciding therapy for older patients. Dr. Cloughesy, you want to discuss a little bit about it?
Sure.
Just in summary.
And you know, I mean, again, these are discussions that we have together with Dr. Kaprealian, trying to understand the size of the radiation field and then the relative sensitivity of the areas being radiated. We know the temporal lobes and the frontal lobes are a bit tough. Like in this patient, it would be a big field. It would be in both frontal lobes. You know, that may not just be the best way if we didn't have to consider radiation for the patient. If it's more posteriorly placed, smaller, I think there's a huge advantage to radiation. So you really have to be considering that. It's more about what's going to happen a couple months after they're done with radiation. Of course, the MGMT methylation status we discussed, the performance status, whether or not we feel they could tolerate radiation therapy at the 60 gray, giving a full 6 weeks, or the 40 gray. Fragility is maybe even a little different than performance status because, you know, it takes into account a number of other things, but it's kind of hard to measure. But when we see the patient, we know what we mean. And I think, you know, maybe the family understands that too. But really the most important thing, nobody understands more about what they want to do than the patient themselves. And especially a patient who's a bit older, who just has a clear understanding of what they would like to do, what they wouldn't like to do. So they're the ones who finally decide our job is to educate and provide the best information we can so that they can make a final decision about how to move forward.
Right, thank you. Pretty much just so in summary for the patient actually opted to start just temozolomide alone as his own decision. And the patient actually, even after 9 cycles of chemotherapy, which is a little bit longer than we would probably do these days, but still did very well without any tumor growth. I'll move on to the next case. This is on the opposite end of younger patients, 41-year-old, who also presented with a left arm focal motor seizure, also a very healthy patient with no past medical history. So Dr. Pope, if you could help with the imaging.
Sure. So again, we have our classic T2 weighted image, and this looks to be a post-contrast T1 weighted image. And we do see, again, an area of abnormally bright signal intensity in the right frontal lobe. But in contrast to the cases we saw previously, we don't really see much in the way of enhancement of that same area. So in this case, we would be concerned for tumor as we were previously, but the fact that there's no contrast enhancement would suggest that this may be a lower grade tumor.
So I'll have Dr. Everson discuss the surgery decision.
Yeah, so as Dr. Pope described, what we think we're dealing with here is a lower grade tumor. Anatomically, it looks like it's located either within or very close to a very functional and eloquent part of the brain called the motor cortex. And with our fMRI and DTI mapping, we can outline that. And we're overlaying here the motor fibers in green with the motor hand activations, which are seen there in yellow, and the tumor, which is seen in purple. And as you can see, it's really pretty wrapped up, or at least adherent to one side of that really critical connection between the motor cortex of the brain and the cortical spinal tract, which travels through the brain into the spinal cord and out into the distal musculature, which allows for movement. So if we cut or interrupt that with our surgery, we can cause paralysis that may be irreversible. So any manipulation in this area has to be done extremely carefully. The second feature is, because it's one of these non-enhancing, what appears to be potentially lower grade tumors, we know that they often have a pretty indistinct margin. It's hard to tell under the microscope even where the tumor begins and ends. They grow more in a gradient fashion. And so there's not a clear idea of exactly where to stop, especially when you're in sort of a homogeneously appearing subcortical portion of the brain. So in this case, we can't look just visually at what happens with the tumor. We have to use physiology. And our next slide outlines kind of the techniques that we do. The brain, the nervous system is all electrically mediated. We can test and find the resulting sort of activation of this motor system by putting a strip of electrodes on the brain over the region of interest, and we can stimulate a little current through each one of those silver electrodes, and we can find which area results in movement, the motor system being activated. That helps us outline where it begins and ends. We measure that in real time with neurophysiology team looking there at the responses on a monitor and seeing the different waveforms. And we can see that in that middle graph there, that we get the most robust activation of the motor fibers over a certain area of the brain. That gives us a map of where we can go in. Once we're on the inside though, we have to continue our physiologic mapping. As we start our resection, we're probably going to start as far away from the motor fibers as possible, and continue to shave down or remove tumor bit by bit, getting closer and closer while we're monitoring to make sure that we do not enter into the motor fibers. I think Dr. Kim in his talk earlier may have explained how we do this, but basically we can stimulate now the subcortical deeper parts of the brain with a electrode, and that's what's depicted here on the right-hand side. And we can do that each time to see if we trigger a motor response at a given amount of amperage. And as we get closer and closer to the actual tracks, the amount of stimulus required to trigger that response will get smaller and smaller until we're right on it. And that tells us really how far we have, how much of a margin do we have before we really enter into those motor fibers. And that gives us an idea of where to stop removing tumor, as it could be entering into those motor fibers, and further resection would result in potentially irreversible paralysis. So when we use those kind of techniques in something like this, we're taking it out in a different technique altogether. This, we're sort of shaving down bit by bit a portion of the tumor, whereas in the previous cases, we might be able to cut all the way around it and remove the tumor in a single solitary piece. So very different approach surgically, a different operation altogether. But using these kind of techniques to keep everything safe, we can still accomplish a lot. Now, knowing that this is really wrapped up in the motor, we're probably not going to be able to remove 100% of it, but we can remove it the vast majority and leave a little margin as it enters into that functional area, because we know that doing that and relying on subsequent treatments, chemotherapy and radiation, is a much better situation to be in than taking out the entire tumor but leaving someone hemiplegic, meaning they can't move half of their body, because they will not be able to go on and get benefit from those additional treatments. And so our next slide shows what we're able to accomplish in this case by chasing the margin posteriorly as it entered into the motor cortex, perhaps leaving a small rim of disease there, but keeping our patient neurologically, functionally intact in terms of their motor strength and function. Our other images here give a few more looks at that. Maybe Whitney, I don't know if you want to comment on that.
No, I would just reinforce what you said, that certainly the vast majority of the tumor has been resected successfully. And again, the margins look very clean. And as you mentioned, there could be a small amount of residual tumor along the posterior or back part of the resected cavity.
So I'll have Dr. Rodriguez go over the pathology.
All right, so here we are seeing another example of an infiltrating glioma. On the upper left-hand side, you have something that we sometimes describe as cellular monotony, that the cells look a bit round and have some clear halos around. This will show some of it a little bit in the previous case, and which was a component of a more aggressive neoplasm. But here we see that the cellularity is low, which is reassuring, and the cells, they don't vary much from each other, and they have these round nuclei with halos. That's something that is that helps us recognize it as oligodendroglial-like, because referring to their similarity to oligodendrocytes, which are a specific cell type that you see that is responsible for that you see in the white matter of the brain. On the right-hand side, in contrast, you see this increase in cellularity. The cells look more back to back. At low power, we sometimes refer as being too blue. That is something also that tells you have more cells. So these can vary from part of the tumor, and tumors now we know can be very heterogeneous. Can have areas that look more low grade and more higher grade, and more cellular, like that one on the right-hand side. On the lower left, this is a special immunostain Ki-67, which recognizes cells that are proliferating, they are growing, so they are dividing. So here is 10 to 12%, is somewhat increase, not as much as that glioblastoma that we saw, but it's going a little bit up there compared to normal brain. And then you have a mitosis, which we can see still with H&E, which also tells you, this combination tells you the tumor is having areas of proliferation. So using the 2007 WHO, this was reported as anaplastic oligodendroglioma, meaning it's oligoendoglial, but then in addition to that, it has areas of increased cellularity and increased proliferation, which puts it into a high grade and a grade 3. And oligoendogliomas are only common 2 grades. They're low grade or grade 2s. Most of them are initially, at least. And then you have the grade 3s. So there are only 2 grades. There's no grade 4, if you notice here, and that's because they, irrespective of how high grade they can be, they don't act as aggressive as glioblastomas do. These are some of the information that we use. We report the Ki-67 usually in our reports. 1p19q co-deletion is one of the basic alterations that is required now for the diagnosis. So in the past, we will put it as an addendum, but now it has become, in the newer WHOs, part of the integral part of the diagnosis. So you see it in the lower field that we need to add that information to the diagnosis to make it meaningful. And IDH mutation was detected by PCR. So there you have the combination of IDH mutation and 1p19q co-deletion is really characteristic of oligoendoglioma. It's one of the main features that we recognize, and it's essential actually for the diagnosis. So it's at the current time, you cannot make a precise diagnosis of oligoendoglioma without at least those two markers being positive. The MGMT here was unmethylated. It's a bit surprising because most are methylated. And there was some monosomy chromosome 10, it looks like, no EGFR amplification. So those alterations, again, that you tend to see more with glioblastomas and diffuse astros. So in the more current WHO, we call it oligoendoglioma, IDH mutant and 1p19q co-deletion. We don't use the terminology anaplastic, we use a numerical grade. And something else that has changed also is that we're using the more friendly Arabic numbers for the classification now for the grades compared to the past that we used to have Roman numerals. And so those are some minor changes that have come up in the classification. And then a list of all the other relevant alterations that were found.
So in this case, now this patient has a slightly different diagnosis than the other patients. So we're going to discuss the different treatment options. So Dr. Lai, I'm going to ask if you could weigh in.
I'd be happy to. So this as Dr. Rodriguez mentioned, this is now what we call a grade 3 oligodendroglioma. And the most important factor there is the 1p19q. Interestingly, as he said, the patient was unmethylated for MGMT, and you've heard how important that is. We did a retrospective study here at UCLA and found that the MGMT methylation is really important for the glioblastomas that we were just talking about in case 1 and 2, and also for grade 4 IDH gliomas, but not so much for the grade 2 and 3s. So, if your tumor is unmethylated, but you have an oligodendroglioma, I wouldn't worry about it too much. It doesn't seem to affect outcome. So the options that we have for this patient, radiation therapy at a dose of 60 gray over 6 weeks. I think Dr. Kaprealian will talk about the radiation dosing. Option 1 plus concurrent adjuvant temozolomide. And option 3, as you can see, it's in red, is PCV, which is a combination of procarbazine, CCNU, and vincristine before or after option 1, which is radiation therapy. What we do here at UCLA is that we do the radiation alone, unlike for the glioblastoma where there's chemotherapy combined with the radiation. In this case, for oligodendrogliomas that are 1p19q co-deleted, radiation is given alone, followed by a 2 to 4 week break, and then continue with PCV. The other options here, radiation therapy at a dose of 50 gray over 5 weeks, chemotherapy alone, best supportive care. Best supportive care is always possible. I did want to take one little step back and kind of explain why at a patient conference we're showing all of this data. And, I think everything that we do here at UCLA is to some degree data-driven. That gives us the structure, that gives us the starting point by which we can start making recommendations. Obviously, as Dr. Cloughesy said, every single patient is different, and we end up tailoring the treatment, based on other factors. But the starting point is all data-driven. So this is a trial, EORTC. This was done in Europe, 26951. And there's just so many things in these curves that I want to point out to you. And the main thing is that when they looked at the specific 1p19q co-deleted group, so they took out the ones that were molecularly oligodendrogliomas, and these were anaplastic oligodendrogliomas, so grade 3. what you see here, and I hope I can show, so the circle is when you added PCV to radiation versus the blue curve where you just have radiation alone. And there's this clear separation. There's a couple of things that we've learned from these trials is that sometimes the publications are prepared and published early on. So at 7 years, because these curves are overlapping, there's no apparent difference. But then as you let the data, quote unquote, mature, as you get, even at 8 years, 10 years, 12 years, 14 years, that's where you see the greatest separation. So what we're seeing here is with 1p19q co-deleted patients that have received radiation and PCV, we're seeing this curve plateau or flatten out. It's going down, and each time it goes down, that reflects a patient dying. But when it stops going down, it means that, and then we look at the percentage of patients where this has stopped going down, and that's actually at over 50%. So what this is telling us is in this specific trial, at 14 years, greater than 50% of the patients were still alive. And so when I see patients with the 1p19q co-deleted tumors that I think can withstand the treatments, I'm extremely enthusiastic and optimistic for them. And I'm also making a very strong recommendation that we need to do treatment, this regimen of radiation and PCV.
So let's talk about the radiation.
So the radiation that we've been doing is very similar to the one I described for the grade 4 or glioblastoma, which is true grade A for 30 treatments. That there isn't currently data based on all the new categories that are coming up as how Dr. Rodriguez just described. Currently, the radiation doses are lumped more together, high grade versus low grade. That being said, just like Dr. Cloughesy mentioned earlier, sometimes we take things case by case. And there have been a couple of patients who had a lower aggressive profile, and it was an oligodendroglioma, glioma, and we've kind of tweaked the dose a little bit and brought it down. But for the most part, just kind of standard overall, it's high grade gets 60 gray, and then the low grades get a little bit lower at typically 54 gray. So this patient got 60 gray, similar margins were used. I guess can I use an arrow or just I have to point?
You can do the.
Can you see this arrow now? Or
no, yeah, the arrow won't work. You have to do the circle thing. There you go.
Well, I just put can you see that?
Cool. Yeah.
Okay, so that's my gross tumor area or resection cavity. And then the blue is my margin, and again, focusing in on all the dose to that area. You can also tweak the margins a little bit. So if it's a higher graded glioma, but we think it has a lower risk profile than a grade 4, such as this case, you can go smaller on your margins than you would a grade 4 that's more aggressive, than a grade 4 that's more aggressive, like a glioblastoma. So there are things that we can do case by case.
Right. So I think on that note, I'm going to go to the next case, which is actually a low grade case. I'll take care of it.
Okay.
Which is also another young person who has this scan. Dr. Pope, you want to do a quick explanation of the scan?
Sure. Here we see in the region of what's called the insula and the overlying temporal lobe, we see an area of rather homogeneous T2 signal increase. Again, this kind of whiter color on the scan. And when we look at the post-contrast images, we just see some spots here, and those are the blood vessels, so those are normal, but we don't really see any enhancement of the tumor itself. So this looks like a non-enhancing tumor that's centered in the left insula.
So surgery on this patient.
So lesions like this can pose a real challenge to us as surgeons for several reasons, which, the location here anatomically, involves potentially multiple functional systems in the brain. The portion that's in the temporal lobe might involve the hippocampus, which is involved in memory formation, and other portions in the insula and beyond are involved potentially in the speech language system. And then the deep portion of this, as it gets towards structures in the brain called the basal ganglia and internal capsule, can border on motor and sensory systems. So really all of the major systems are potentially at risk for a surgery to remove a tumor like this. And we'll typically need to balance that between the apparent low-grade type appearance of this, and balance all of those factors together. So again, we rely on our pre-surgical mapping, our functional MRI studies to understand where the language systems might be located, as well as which, proving and confirming which hemisphere of this patient's brain is dominant for language and memory systems. And the probability studies would tell us that about 90+% of people, their left hemisphere is dominant, and that was the case in this patient here. There's an additional type of study which is mentioned on the next slide called a WADA test, which is a test that's done in interventional radiology, where a drug is injected into one hemisphere of the brain, which sort of temporarily inactivates that hemisphere, and that further can confirm whether or not, sort of taking that hemisphere offline, it knocks out the language and memory systems and further confirms hemispheric dominance of the brain. So if a test like that or the functional MRI, proved that the left hemisphere was dominant, we would know that a surgical attempt to remove this entire lesion, really would put all of those major functional systems at play. Beyond that, beyond just the functional systems, are the sort of deep arterial anatomy of the brain gets complicated for tumors in this region. You've basically got in the depths of this mass a bunch of fine blood vessels, which each supply blood to really important parts of the deep structures in the brain, the basal ganglia and thalamus, as well as blood vessels which sort of travel over this area, which go on to supply other critical regions of the brain, like the motor cortex. And so, you're really entering into high risk territory with a surgery on a tumor like this. And for this instance, weighing all these factors, we elected a strategy to mitigate against all that risk, but still establish some important things that we can do surgically, like number one, reducing the number of cells, and number two, confirming the diagnosis. So using our pre-surgical mapping, we can determine that parts of the temporal lobe are going to be the safest surgical target. And so in this instance, that's what was done at surgery, a modified sort of minimal temporal lobectomy, excluding the deep structures of the hippocampus, excluding the part that enters into the insula and puts all those speech and motor functions at risk. And what we've got on the next slide here is sort of the results of that, in that a sizable part of the lateral temporal lobe is removed surgically, but the deep structures, the deep portions of the tumor that crawl into the insula and beyond are left intact, in place, to mitigate against the risk of the functional deficits that could be acquired by, too cavalierly entering into those areas. That other slide there does make a note, to do this well, you have to understand, the full three-dimensional anatomy, and there's, some looks can be deceiving, but, in this day with our really amazing imaging that we can get here, that's not such a surprise anymore.
We'll go through neuropathology.
Okay, and here we have, and yes, you can see as a theme of what we call diffuse gliomas. These are tumors in which the cells kind of infiltrate the brain in a single cell level. That's why they are in many ways very challenging to treat. So you have in the left-hand side what we call a low power view, and the cellularity, I will say, is kind of moderate. It's increased. We can recognize it as increased compared to normal brain, but not to the extent that we saw with an anaplastic oligoendoglioma and the glioblastomas. Here on the right-hand side, upper corner, you see a higher magnification view. You can start seeing the individual nuclei. And here you can see the variation in the morphology, in the shape. That is something very typical of astrocytic tumors compared to oligoendogliomas, for example, that we saw earlier. And the lower left side, you have an immunostain. We stain for proteins with a variety of proteins that's the technique that we use as immunohistochemistry. And here we stain for GFAP, which is a marker of glial tumors, particularly astrocytic tumors. They tend to have all these processes that are GFAP positive. It's one way how we recognize it as astrocytomas by other methods. And you see here that on the right-hand side, the Ki67, again, a marker of cells that are dividing or in the cell cycle that are actively dividing, is something that you don't see in normal brain. Here, you do have some increase compared to normal brain, 1 to 2%, but not to the extent that we saw, again, in the other higher grade tumors. So this is actually reassuring. It tells you that the tumor is proliferating, but at a very low rate. We can go to the next. So in 2007 and even 2016, we will have called this diffuse astrocytoma WHO grade 2. Now, in 2016, the IDH information was added. So we need to add it whether designate whether they're IDH mutant or not. And in the more current one, the terminology of diffuse astrocytoma or grade has been supplanted by just calling it astrocytoma, specifying whether it's IDH mutant and also the grades. And they can go from grade 2 to grade 3 to grade 4. Grade 2 is at the lower grade of the spectrum. They all start at grade 2s, these diffuse gliomas, and they have very little proliferation like these tumors. So this is in some ways the best you can get within that group of tumors. And a grade 3 will have more proliferation, and a grade 4 will have areas that are very similar to glioblastoma with a lot of necrosis and vascular changes. So this is at the lower end of the spectrum based on proliferation. It does have IDH mutation detected by PCR, and it's MGMT methylated, which again is a good prognostic factor. And many of these IDH mutant tumors, both astrocytic and oligos, the majority of them are MGMT methylated. So there is there's somewhat related, not 100%, but there's a big overlap there.
Dr. Lai, do you want to go over treatments if the patient had complete resection?
Yeah, so for patients that have had we'll start with patients that have had a complete resection, not exactly this case, but whether it's an oligodendroglioma or an astrocytoma, we actually recommend watchful waiting at that point. So there's no need for immediate treatment. In terms of incompletely resected tumors, this goes into this high risk, low grade category. And what we found here was that the early radiotherapy improved progression-free survival, but there was no difference in overall survival. So what it said was also in the incompletely resected group, we could also delay radiation. I wanted to make one comment though. There was a question about why the data is why are we showing data that's this old, and the main reason is that's what we have right now. But there is a complication because low-grade tumors at that time were not categorized the way they are in 2021 with everything that Dr. Rodriguez is talking about. So while the majority may have been IDH mutant tumors, not all of them were, and plus we weren't able to, didn't necessarily have the 1p19q as well.
So in this case, the patient actually decided that he didn't want to undergo treatment yet, although technically he would be in the high risk group. But he did start having more and more seizures, and then decided that he wanted to undergo treatment after. I'm sorry, I'd like to answer some patients' questions, so I thought I'd go a little faster with some of these cases at this point. And he, so for a patient who then opted to get treatment, Dr. Lai, do you want to start talking about the treatment options?
So these are the options: radiation therapy alone, and I think Dr. Kaprealian will talk about the dosing, PCV before or after option 1, enrollment in a phase 3 clinical trial with AG881. That's something that we have finished enrolling in. Chemotherapy alone, radiation therapy with 60 gray, surgical resection. Option number 2 here is radiation plus concurrent and adjuvant temozolomide. So what we are doing here at UCLA, or we're trying to do, and this again is we will tailor it for a patient, but we are trying to do PCV before or after radiation, and typically we're doing it after radiation instead of temozolomide. And I think the next slide will talk about some of the data. So yeah, this is our TOG 9802, and this 98 signifies that it was this was actually initiated in 1998, so that is 24 years ago. But what it clearly showed in the high risk, low grade astrocytomas and oligoastrocytomas that radiation plus PCV was superior to radiation alone. And hopefully you've gotten used to looking at these Kaplan-Meier curves, and we look at overall survival, and this just shows that with the circle and the yellow, that's radiation plus PCV, and that is radiation alone. And you can also see here with 8 years of follow-up, greater than 50% are alive and doing well at 8 years. But there are the caveats, as I said. There was insufficient 1p19q biomarker data. The samples were, I don't think they had enough to really even differentiate which ones were IDH mutant in there, although we do know that most of them would have been, but still that can definitely create noise. And I think, so what you might be saying, well, why are we using PCV if you said PCV is really great for oligodendrogliomas? Again, we're following the data. So this even though it's from 1998, is read out more recently, we don't have a head-to-head comparison between PCV, which is a combination of 3 chemotherapies, procarbazine, CCNU, and vincristine, versus temozolomide. Temozolomide would not be the wrong answer, and a lot of institutions are using temozolomide. But we have this data which clearly shows the benefit of adding PCV to radiation. We don't really have the same data comparing PCV and temozolomide. I think that's coming up. But we do tailor our treatments based on the patient. And I think most people would agree that temozolomide is easier to administer than PCV, and it's easier on the patient. But with data like this, we are trying to do radiation plus PCV for these patients.
Dr. Kaprealian, you want to talk a little bit about radiation?
Yeah, it's very similar to the prior images that we saw. The only difference is that the margin would be smaller than a high-grade glioma, and the standard dose for a low-grade glioma is 54 gray. Typically, we would do it at 1.8 gray daily fractions over 30 treatments, and really that's the main difference between the two.
So just a summary of a lot of the things that Dr. Lai spoke about. We do consider watchful waiting for the grade 2 gliomas if they had gross total resection. So we consider what's the extent of their residual tumor. We want to make sure that they have an IDH mutation. Of course, that's changed a little bit now. They have to have an IDH mutation to stay at the low grade anyway. Their patient's age, how much of the pathology may be indicating a higher, faster growing tumor. And it does look like if we do treat, we want to treat with radiation and chemotherapy, since those data show that it's better than radiation alone. And again, because of the data, we do prefer using PCV for the low grade tumors, because that is what is available in our data. Although we really don't know yet what to make of temozolomide. So if we have results, that may change. Again, I think also to just explain why these data are so old is, these patients with low grade tumors do well. And so it can take many years before we start seeing some definitive results to actually make sense and make treatment decisions. There's also the idea of IDH inhibitor, which I spoke about in my experimental therapy lecture. However, the trial that we have currently is close to enrollment, but we'll have results in the next few years, and that may change what we do in the future for the lower grade IDH mutant tumors. Okay, so on to case 5. This is a 45-year-old Asian gentleman who presented with headache and also a seizure, also very healthy with no past medical history. So Dr. Pope can give a discussion about the imaging.
Sure, I'd be glad to. So again, these are T1 post-contrast and T2 weighted images. And it's quite obvious that there's a large abnormality towards the front of the brain here. And you can see that it's avidly enhancing, kind of homogeneously enhancing area that's well-defined. And if we look closely on the T2 weighted images, what we can see is that there's a very thin white line that goes all the way around the tumor. And that is what we call a CSF cleft. That is, there's CSF between the tumor and the brain itself. Yes, exactly. And so that would indicate that the mass is not actually within the substance of the brain, but is generated from the coverings or the dura of the brain. And we can see that a little bit better on the sagittal image here and the coronal image, where it's extending to the meninges or the covering of the brain. And so because it's not in the brain, but rather not a tumor of the brain itself, but a tumor of the brain coverings, we have a different differential diagnosis or a different list of possible tumors. But this tumor has a classic appearance for a meningioma. That is a tumor of the meninges.
Dr. Everson.
So here the radiographic appearance is really paramount, and when we're settled on something that we think is a meningioma, becomes a very different surgical exercise or technique to remove a meningioma, mainly because of the factor that these are growing from outside the brain and displacing the brain rather than growing from within. That has a couple of different implications in terms of what symptoms they might cause, how they might cause them, or what size they might be before they cause symptoms. Secondly, it has the implication that we, instead of going into the brain itself, we should do everything that we can to stay outside of it and preserve the normal brain architecture and not risk a functional consequence or deficit related to that. The presence of that CSF cleft that Dr. Pope mentioned is encouraging to us as surgeons that the tumor is probably not stuck to or invading into the brain, and gives us an idea of what the planes might be like anatomically to be able to separate the tumor from the surrounding brain. The other problem though that we run into is that while it is outside the brain, the other structures, important structures that are just outside the brain, are the blood vessels, both the arteries and veins, and those can be wrapped up to or intertwined with the tumor in a delicate or dangerous, potentially dangerous way if those vessels are injured. So that is something that has to be appreciated. And then finally, what's shown here is the grading scale for resecting a meningioma. And not only the bulk mass itself, but we know that tumor cells can actually integrate into the covering of the brain, the dura, which is where these tumors originate from. And those cells can kind of radiate out at a margin. And if we are able to remove that margin, we can effectively cure these tumors. But if we can't remove that margin of the covering of the brain these come from, there's a higher rate of recurrence and therefore a greater need for other potential adjuvant therapies that we'll discuss after that. So the grading scale basically says if we can remove the bulk tumor mass as well as its attachment to the dura all the way around the tumor at 360 degrees, that's the best chance and we have the lowest rate of recurrence. If we can only sort of coagulate or burn the dural attachment because it contains some critical blood vessel or structure, then we get a slightly higher rate of recurrence over 10 years. If we're lower than that, we get even higher, all the way down to just taking a small biopsy. By definition, the tumor has sort of already recurred at that point. So for this instance, we're looking at a very different sort of technical aspect from a surgery. We're looking at how do we remove all this and its attachment. Now, if we go back to the imaging, we can see that this originates from part of the major veins in the brain called the sagittal sinus, and whether or not involving that in the surgery depends on sort of where that is and whether or not there's blood flow through that major venous structure. In this instance, if there was maintained blood flow through that, we can see that on the scan, and that part is preserved. So we're able to accomplish, this grade 2 resection where the entire bulk mass is removed, but the attachment to the dura is left in play, and that goes into our prediction, our probability of how or when it might recur, and how to surveil that in the post-operative setting. But with all that, we can remove the large, majority of the mass through a craniotomy, much in the same way that we showed with gliomas, and in this case, stay completely outside of the brain, and therefore, put it at significantly lower risk for deficits related to injury to the brain directly, as long as we can stay outside and that plane is maintained and preserve all of the arteries and veins in the surrounding region.
Want to discuss the post-operative MRI, Dr. Pope? Other than
Sure. Yeah, we can see again an excellent resection where all of the nodular enhancement has been taken out, so we don't see any of that meningioma remaining. And meanwhile, we've been able to preserve the superior sagittal sinus, it looks like, so there's no injury that we can see to the adjacent blood vessels. And we see that there's some persistent edema in the brain, some swelling here on the T2 weighted images. But that we expect the brain will kind of bounce back as it occupies a space previously occupied by the meningioma and kind of regathers its normal configuration. You would expect that to abate as well. So it looks like a very good outcome.
so on neuropathology, Dr. Rodriguez.
Yep. So, okay. Yeah, I thought I was mute there. So, we're seeing here the histology of something that is a bit different. This is a different category of tumors compared to the others. Here, we say that this is a tumor that grows in a more solid fashion compared to the infiltrating gliomas that we were discussing previously. And on the upper right-hand side, you have a high magnification that tells you that the cells are kind of close to each other. They don't have very clear cell borders. That's one of the features that we associate with meningothelial tumors. They almost have a tendency to make whorls. It's something also that we recognize that is very typical of many meningiomas. And we are seeing mitotic activity. So also for meningiomas, as for diffuse gliomas, we do use mitotic activity as a way to grade them, with the idea that the more mitosis that you have and more proliferation, the higher the grade. And you do have necrosis on the left-hand side. Now, necrosis, it is one of the factors among others that we use for grading. But in meningioma, something that we have to, from our end, have to make sure is that the necrosis is spontaneous. Some large meningiomas occasionally get embolized or get prior to surgery, or they have other, historically that's used to happen more. And that type of necrosis is not used for grading. So those are things that we need to have in mind. But the proliferation is one of the main factors that we use. And here, 6 per 10, 6 mitosis, we count them in a subsequent high power fields. So if you have 6 mitosis over 4 mitosis per 10 high power fields, then we are able to place it in the atypical or grade 2 category. We can go to the next one. Ki-67 matches the proliferation index, matches the proliferation seen by mitosis, so they many times go hand in hand, or is over 5%. So the special technique plus the histology is really providing, it's consistent with a tumor that has a higher proliferative rate. So this was called an atypical meningioma. Is our classification hasn't changed very much in the WHO. Still only it's a grade 2. So meningiomas can be graded in 3 different ways. There are 3 different grades of meningioma. Most meningiomas are grade 1, in which you have very little proliferation. Those tend to be to behave the best. Then you have an intermediate category, which are these, the atypical meningiomas, in which you have proliferation above 4 mitosis per 10 high power fields, but less than 20. And then you have the anaplastics or malignant or grade 3s, which are very proliferative tumors, have a lot of other bad features, and they have the worst prognosis among the meningioma categories. And now, as I mentioned, for the WHO, we're adding information about the different molecular alterations they may have. And this one had a truncating mutation in the NF2 gene, which is one of the most common genes that is altered in meningiomas, the NF2. So atypical meningiomas, these are some of the, again, some of the separation, the criteria you have for grade 1s, 2, and 3s. Most grade 1s, most of them are grade 1s, 70 to 80%. Then you have an intermediate, you have 20 to 25% grade 2s, and a small subset are grade 3 or anaplastics. And there are some rare morphologic variants that have also are a bit more aggressive, and we place them in those categories. Like there's one called clear cell and choroidoid that makes, by definition, they're grade 2, and papillary and rhabdoid grade 3.
So I would mention that for meningiomas, most of the treatment options are actually just surgery and radiation therapy. There's also the idea of most meningiomas are grade 1 and slower growing, so we could just watch. Chemotherapies are generally not effective, so we do not have a lot of medical treatment options. I'll explain about that at the very end. I'd like Dr. Kaprealian to discuss about whether you would radiate this patient who has a grade 2 meningioma that looks like completely resected.
Yeah, for patients like this, where you have a complete resection of their grade 2 meningioma, we talk about watchful waiting versus radiation. If it was a subtotally or partially resected grade 2 meningioma, we would definitely recommend, 100% we would recommend adjuvant radiation therapy. But in this setting, we kind of go over the picture and the options. One option would be very close monitoring, and at the first sign of growth, small growth, then we would start the radiation therapy at that point. But we also do offer just upfront radiating the tumor at that time, and give the patient the option, and we work as a team. And so this patient actually opted to get treated. After he preferred just going along with it and just kind of getting it over with, as he had said. And so The dose for grade 2 is 1.8 a day for 31 treatments for a total of 55.8 gray. That's kind of this in-between dosing we would use between a grade 1 and a grade 3 meningioma. But for the grade 2s, if you read up on any of the literature and data, the dosing is really all over the place between 50 and 60 gray. This is I would say it's good to go over 54 gray and keep it up to 60 gray for a grade 2. The margins are smaller than you saw for the gliomas. They're tighter. There's less of that infiltration that's expected, particularly for a grade 2 compared to a grade 3. So it's similar concept, but smaller margins.
I think this is, yeah, yes.
Okay, so this is just showing postoperative radiation therapy in a group of patients with atypical meningiomas. So it's split between gross totally resected patients and subtotally resected patients. So GTR is the gross total, STR is the subtotal. And you can see in the gross total resection category, 10 patients had received radiation, none recurred. 104 patients did not receive radiation, and you had about a 25% recurrence. Then looking at the subtotal resected group, you have 32 out of 68 patients, 32 patients had radiation and about 25% recurred. And in the group that did not get radiation, so 36 patients, approximately 50-50 split here, you had a 47% recurrence. So you can see that if you had a gross total resection and did not get radiation, it's about a 25% recurrence. If you had a subtotal resection and got radiation, it's about a 25% recurrence. So the worst group would be the subtotally resected and not getting any radiation. So that's why I said if you have a partial resection, we would definitely say you need to get radiation therapy at that time point. Whereas if it's a gross total, we can wait it out if the patient really opted to do that. And this is just looking at, again, kind of similarly observation versus adding adjuvant therapy. And the A is progression-free for survival in the top graph for A, and then B is overall survival. And the 5-year progression-free survival for the observation group is 79%. But for the group that got radiation, it's 88%. So although the statistical significance is low, this is clinically kind of what we see and what we would how we would recommend things for our patients, treatments for our patients.
So as we mentioned, from meningiomas, most of them are grade 1, and usually we are able to just do surgery with those, but if there are treatments that are needed for meningiomas, especially if they're grade 2 atypical meningioma or grade 3, we would consider radiation. And usually most meningiomas, though, since most of them are grade 1, can be monitored for years without further treatment. There are some instances, though, we have to consider other treatments beyond surgery and radiation. So in cases where if the patients already had radiation, already had surgery, that had further growth and more radiation cannot be done, we may have to think about alternative treatments. Also, I would note that there are special circumstances when the meningiomas are related to genetic diseases like NF2 schwannomatosis. I just wanted to say very briefly that there are no medical treatment options for meningiomas, no approved medical treatment, no FDA approved medical treatments. But like this patient we noted, a lot of patients can have a mutations in a protein called NF2. And so just like what I explained about experimental targeted therapy for gliomas, also with meningiomas, we can also start looking at targeted therapy based on the molecular diagnosis of the tumor. So these are maybe future options for treatment for specific molecular aberrations for patients with meningiomas who may be growing back after they've already exhausted other treatment options. So that's kind of an overview of what a brain tumor board looked like. We all discuss cases and decide together. Again, we base our basic decision on data like Dr. Lai mentioned, but then we try and also take into consideration patients' individual characteristics to make the final plan for the patient. And it's really required the whole group to make these decisions. I just want to remind everybody that please leave a conference comments using the survey. You can use your phone and take a picture of this QR code, but it's also in the chat where you have the link, and then we'll also email a reminder for you to send in your conference survey. So at this point, we're just going to try and answer some of the questions that have been brought up by various people over the day until we hit 5 o'clock. But actually, I think the most common question that has been asked today, Dr. Cloughesy, I'm going to give this to Dr. Cloughesy, actually, has been over the DCVax trial. A lot of questions such as, what's the difference with the one that we're using at UCLA versus the product that was used in phase 3 clinical trials that was in international phase 3 clinical trials where we don't have the data yet. And just so everybody knows, yeah, it's not here. Dr. Cloughesy is going to answer as much as he can.
Oh, I mean, they're very similar. I don't think there's really a substantial difference. They were just, made at different centers. The ones that we make here are made here. And so otherwise, there's minor differences between them.
I think people were wondering, where's the data on the phase 3 trial?
Well, it's going to be presented by, I think they just had a
press conference.
A press release,
yeah,
saying that it was going to be presented by Dr. Leia on the 10th of May.
New York.
See if I could get the exact thing. Yeah, at the Frontiers of Cancer Immunology Therapy Conference, New York Academy of Sciences. So looks like it'll be at 11:10 a.m. I'm assuming that's Eastern time, but I don't really know. So that'll be May the 10th.
Maybe you can briefly explain the difference between our current clinical trial with the vaccine.
Oh, the trial itself. Yeah, well, so first, this phase 3 trial that was done by Northwest Biotherapeutics is used in the newly diagnosed setting. So what happens is patients have a surgery. Those tissues from that initial surgery are taken to make the vaccine with, but they undergo radiation and chemotherapy. And then after completion of radiation and chemotherapy, they have an MRI scan about 4 weeks later. And if there's no evidence of tumor progression, then the patients were randomized, even though the vaccine was made, and during that time frame in between radiation and or having the tumor obtained and then getting ready to go forward with the study, they were randomized to get the vaccine or a placebo, and they went on and continued with the treatment. Now, at the time of progression, patients were allowed to cross over, so there was an opportunity to get the vaccine after. So I think everybody had a chance to get the vaccine. Our setting is in the recurrent setting. It's in first or second recurrence. Everybody has a surgery, but before surgery, they either receive pembrolizumab that is given 2 weeks before surgery, or a placebo. And then after a surgery is completed, the blind is broken, or I should say, until after the vaccine is given. Everybody gets the vaccine. They get the 3 doses of the vaccine, And then that's when the blind is broken. So then that's when patients understand whether or not they received pembrolizumab or not. And that study really, various endpoints are really more molecular endpoints. The study is not large enough to have an efficacy opportunity to differentiate between the two arms in any way. The totality of the data potentially will be used and compared, but it's not really a study that will give, and as part of a registration study, will provide information about FDA approval in any way.
So just so everybody know, we're, I think, got 15 or so enrollments out of the 40 patients or something like.
I mean, 15 that are left?
I
There's
don't
like
remember.
20 some odd
We're
that have
about-
been enrolled, yeah.
Yeah, so we're about halfway, I think.
Yeah,
Probably
definitely halfway.
Be the best to put it for that trial. But again, it's not, I think I just want to make sure, because there were quite a few questions about it, this is not the same thing as a phase 3 trial. It's not meant to be an FDA registration trial. We are trying to understand whether the addition of pembrolizumab can make the vaccine work better, and it's more to answer, scientific reasoning to improve treatments using immunotherapy for patients with glioblastoma. So it's really different questions, different scenario, different patient population. And is this something that is being done only here at UCLA? But otherwise, vaccines are very similar in how function. Some other questions that have been going on throughout the day. I have one for Dr. Rodriguez. Just, we spend a lot of time talking about gliomas, but a patient was asking about having a rosette-forming glial neuroma of the fourth ventricle. So I'm just wondering, where does that fall into all the things we talked about today, or is that a really rare tumor?
Yes, indeed. That's an excellent question. It's a rare tumor. So we focus a lot on gliomas, meningiomas, just because those are the tumors that we encounter more frequently in clinical practice. But there are over 100 tumor types in the WHO classification that we see also sometimes in the more rare. And one of those is rosette-forming glioneuronal tumor. This is considered a low-grade tumor. So it's assigned under the WHO a grade 1. In some ways, it is related. You can say that some of the areas can even look a little bit more overlapping with pilocytic astrocytomas, which I discussed a little bit. It's one of the tumors that you tend to see more in children. So they tend to be circumscribed, and they don't tend to infiltrate the brain as the diffuse gliomas do. That being said, from the question that was mentioned from the patient, it looks like that was a case that recurred several times. So one problem that we have in the brain is that we may call something low grade, but you still can have a lot of problems from the tumor, even when they are considered low grade. This is something that is very distinct in the brain because it depends on a lot of locations. Sometimes when they're in the fourth ventricle in that area, they may be not amenable to be resected completely. So that they can recur and they can disseminate, even when everything else, even if they have low proliferation, and even if they're considered low grade. So, but it is a rare tumor. Many of them do well after resection. Morphologically, when we see in the microscope, they are very distinctive because they have differentiation not only of glial astrocytic tumor or astrocytic cells, but they also have what we call neuronal differentiation, features that overlap with that of neurons. So that's a very special group of tumors that have differentiation along the lines of glial cells and along neuronal cells, which are two different cell types in the CNS. So that's something that histologically for us is fascinating, because how tumors can do this. And they also tend to have that was recognized actually back in 2000 in the mid 2000s as a distinct neoplasm based on the morphologic features and the location, the frequent affliction of the fourth ventricle, but we now know that they also are distinctive at the molecular level. So they tend to have alterations in FGFR, PIK3CA, occasionally they have an F1 mutation. So the molecular profile is very distinctive also. So they are a different tumor type, rare. Many of them behave well, but they can also cause problems, particularly with recurrence and local recurrence, and hopefully some of those alterations can in the future be targeted as is happening with many different tumor types.
I think on that question about that tumor type, but really kind of a general questions about different surgical techniques, as well as like what are non-invasive brain surgery. And Dr. Everson, can you help with maybe more of a general statement about these different types of surgery?
Yeah, so there are a couple of questions about some different technologies that we might use in surgery. I think the ones in the question were related to LIT, which is laser ablation, or for a port-based surgery. And I think the important thing to understand is that these are all techniques more or less to achieve the same goal, which is destruction and or removal of the tumor in a similar fashion. The process to approve or get these sort of technologies into the hands of surgeons is much different than it is for like chemotherapy or radiation, where that's really the form of a clinical trial to prove that it's superior. Most of these are just, does this device work to do what it's stated to do, which is, remove the tumor in some way or another. And so while these get the ability for us to use them, the sort of long-term effect or impact of using them is much more difficult to determine. Laser ablation, for example, destroys tumor tissue by burning it, but it leaves it in situ. So that, by its sort of virtue, can only accomplish some of the goals that we can do with an open surgical resection. Like, it doesn't remove the mass, so it doesn't always remove mass effect. And if that's a big issue, then it's not as useful in that regard. Same thing for a port-based surgery. It's just a means to an end. Can we get to a tumor that's deeper in the brain and remove it with a piece of technology that sort of facilitates doing that? But proving that it's superior is a different thing. So, we use these devices. They can make our surgeries or our techniques, more convenient and sometimes, easier in terms of recovery. But ultimately, in terms of the level of effect, the sorts of studies and the data are not there to support, always using them or not. It really just becomes, the preference of the operating surgeon on how and when to use them, much like any other device or technique in an operation. So again, it becomes a very patient-specific, selection and criteria. And so, we've adopted many of these technologies, and we use them in situations that we think are appropriate. In terms of laser ablation, we found that small nodular recurrences, might be treatable with the laser. We found a much bigger use for it in metastatic brain tumors, where we see a lot of tumors that recur, or we see signs on the MRI of recurrence after radiation treatment, for example, and we find it very effective in those settings. And that's the kinds of investigations that are still ongoing, is to really define what the best use of it is, or to use it instead of conventional open surgery, where we have really mountains of evidence to support doing that. So there's a little bit of an uphill climb to decide to use it over those other therapies. I hope that answers those questions. We have those available, and it's a really specific situation where we would employ them.
Thank you, Dr. Everson. I have a question for Dr. Kaprealian. There were actually a couple of questions asking about treating again with radiation. Is that safe? Is that doable?
Yeah, and the quick answer is it depends, and it's case by case. We try to do it if and when we can. If the recurrence is small, even if it's within the prior treated area, we can consider it. If it's larger, or if it's next to a critical structure, such as the brainstem or optic nerves, then it gets a little trickier. But we always opt for safety, of course, but sometimes we have to weigh the risks and benefits. So if we know that the tumor will grow and will definitely cause a patient neurological deficits, then it might be worth taking the risk of re-irradiation where we don't know for certain if it will cause damage. And we kind of go into it as a partnership between the radiation oncologist, neuro-oncologist, surgeon, and the patient, and decide together. So if and when we can, we will re-irradiate.
All right, thank you. I think it's actually 5 o'clock. So, I do want to let everybody know that we have this session recorded as well as the rest of the talk earlier today. We will try and get them up somewhere. I'm not quite sure where yet in the next couple of weeks. Please also leave us a survey of the conference. And we are planning to have more specific conferences with smaller lectures about like meningioma only or astrocytoma only, because I had a lot of those questions today, or various other questions about supportive care, for instance, or the ketogenic diet. In the future, we're hoping that the next one will be able, when we have those small sessions, we'll be able to do it live, and perhaps you get to meet the rest of us in person at that point. So thank you very much for coming to our virtual conference. Thank you for all the speakers today and all the panelists. Thank you for putting in the time doing this with me. So thank you.
Thank you, everyone.